So good afternoon. I wanted to thank you for having me back at this wonderful conference. So this month, I actually celebrated 13 years at Texas Children's. I found a special interest in livers very, very early on, and it's definitely my favorite organ to talk about and to scan. Today, I'm excited to help relieve the confusion about portal hypertension ultrasound. So we will be identifying the different types of portal hypertension, going over ultrasound findings of them all, and then showing some cases where ultrasound was helpful in identifying the types of portal hypertension. So jumping right in, you have a provider place an order that says assess for portal hypertension. So some of the indications that you may come across are GI bleed, splenomegaly, maybe low platelets or hepatomegaly, abdominal distension, or even caput medusa. So in case you didn't know what caput medusa was, this is a clinical and radiological finding, and it can be seen in patients with severe portal hypertension. And here's a physical image of a patient with caput medusa with correlating CT findings showing those dilated superficial paraumbilical veins running along the anterior abdominal wall. And interesting enough, caput medusa is Latin for the head of Medusa. And I think it does kind of resemble her head of snakes. So the first thing we should probably know is what is portal hypertension? So portal hypertension is abnormally increased blood pressure within the portal system. And this happens when blood flow from the portal system, so from the SMV, the IMV, the superior mesenteric vein, the inferior mesenteric vein, the splenic vein, and the portal vein, they meet resistance and they have trouble flowing within to the liver. So how do we know if the pressure is too high in the portal system? Well, the gold standard test is to measure the hepatic venous pressure gradient. And this is usually done in the interventional radiology suite or the cardiology suite. And this test is done under fluoroscopy, where the pressure of the portal system is measured, and then the pressure of the IVC in the right atrium is measured. Those two pressure measurements are then subtracted, and the number represents the pressure gradient between the two. So if the gradient is more than 5 millimeters of mercury, then the patient has portal hypertension. If the gradient is more than 10 millimeters of mercury, then the patient has clinically significant portal hypertension. So why is this important to know if a patient has portal hypertension? Well, these patients are at risk for clinical decompensation. With increasing portal pressures, the body creates portosystemic shunts and collaterals, diverting flow away from the liver. And with these increased pressures on collaterals, they could rupture and cause life-threatening gastrointestinal bleeds. So some of the areas they may bleed from are the stomach, the esophagus, maybe even the rectum. So patients with portal hypertension can also develop hepatic encephalopathy, which is when the liver is not working well and the ammonia is not filtered out from the bloodstream. This extra ammonia travels to the brain and can cause confusion, coma, or even death. And so with increasing backflow into the spleen, it can become enlarged and also cause a reduction in platelets. So the more common portosystemic collateral pathways that we may see are esophageal and gastric varices. And this is a cartoon showing you what the esophageal varices look like. We can also see umbilical vein recanalization in the setting of portal hypertension. We may see rectal or mesenteric varices, and we can also see gallbladder wall varices. So especially in the world of pediatrics, ultrasound can often identify patients with portal hypertension and even the type of portal hypertension that they may have, which we'll be discussing. We can find secondary signs of portal hypertension and to know if it's clinically significant. And then we can also monitor patients with known portal hypertension. So using ultrasound helps patients potentially avoid invasive procedures like endoscopies and some with radiation like measuring hepatic venous pressure gradients. So I am a big believer in waveforms. I believe they show more than just patency. They can tell you the story of what's happening within the body. They can show if there are major hemodynamic changes happening, but it's also important to understand what they mean. And so using this information when evaluating for portal hypertension is key. When evaluating the liver for portal hypertension, it's important to know which probe and which settings to use. If you have multiple probe options, like we typically do in pediatrics, these are the settings and the probes that I would recommend. So for vasculature and the liver parenchyma and the spleen, the curvilinears, they usually are your better option. They penetrate better and they have a wider field of view. For the liver surface or for smaller patients, the linear probe should be used. For an infant, you may be able to do the entire exam with a linear probe if they're small enough. And for the liver surface, no matter the patient's age, if their body habitus allows, always try to use the linear probe to evaluate for surface nodularity. Here's an example of why probe selection is so important. The image on the left is taken with a curvilinear probe. You can appreciate there's probably some irregularity to the liver surface, but the image on the right is taken with a linear probe and with a higher frequency, and it has a much better detail to assess the extent of capsule irregularity. And then these two images were taken with the same probe, but with different settings. And so the image on the left is using an abdominal setting that's good for evaluating the liver parenchyma, but notice how fuzzy that vessel lumen is. The image on the right is a vascular setting, which is much more contrasted, but it clears up the vessels beautifully. So this setting makes it easier to identify thrombus that might be sitting in a vessel. Although I would not recommend it for the liver, you can tell that it makes it look really coarse with this setting. So a sonographic tool that's often used in the setting of portal hypertension is elastography. Basically, elastography is a measurement of the stiffness of a solid tissue. And there's two types. There's strain elastography and there's shear wave elastography. The main difference between them is that strain elastography is qualitative, while shear wave elastography is quantitative. So it gives you a value. There are many, but two types of shear wave elastography that you may see are transient elastography, which is commercially known as FibroScan, and 2D shear wave elastography. So transient elastography is mostly used by gastroenterologists in their office. How does shear wave elastography work? Well, it measures the speed of the shear waves as they travel through the tissue in the body. And these shear waves are perpendicular to the ultrasound beam, as you can see in this diagram. And what to remember is the lower the shear wave speed, the softer the tissue. The higher the shear wave speed, the stiffer the tissue is. And so liver elastography, it's been around for a while, and it's frequently used when checking for liver fibrosis. But now there is another organ that is being sampled with elastography for portal hypertension, and that is now the spleen. So why add the spleen? Well, when portal pressures increase with portal hypertension, blood flow begins backing up into the splenic vein, causing splenic congestion, increasing not only the spleen size, but also the spleen stiffness. As the spleen stiffness trends up, so does the risk of a significant GI bleed. And so there's articles that actually support spleen stiffness being more accurate at detecting portal hypertension and esophageal varices than liver stiffness. So spleen elastography is fairly new, but there is some literature on it being used in the pediatric population. In fact, a somewhat fairly recent article sought to establish normal values of spleen stiffness in pediatrics. And they came to the conclusion that in kids, the normal value was around 2.43 meters per second. But keep in mind that shear wave elastography numbers are vendor specific and they do not translate from vendor to vendor. It's also known that spleen elastography is higher than liver elastography numbers in healthy patients. So at baseline, the spleen is always going to be stiffer than the liver. I think there's a lot more to learn on spleen elastography and the value that it can add to patient care. So keep in mind, elastography is a measurement of stiffness. It's not a measurement of fibrosis. So there's other reasons for the liver to have elevated elastography values. And these include maybe elevated AST or ALT. They may have biliary obstruction or cardiac failure. Also, your liver elastography goes up whenever you eat. So fasting is super important when doing these exams. When liver elastography values are normal, they should be taken as normal. But if liver numbers are elevated, they should always be taken in the clinical context. On the other hand, spleen stiffness increases with clinically relevant portal hypertension, regardless of the liver stiffness. So no matter what is happening within the liver, if a patient has significant portal hypertension, their spleen stiffness is going to increase. And this is why many believe that the spleen is key in monitoring for portal hypertension. As far as technique, every patient fasts for a minimum of 4 hours, no matter what the age. So if we're doing it on a little baby, we are still asking them to fast for 4 hours. Patients fast because it increases the blood flow from eating, and which increases portal flow and makes the liver stiff. It's important to also avoid the capsule. So we scan at least 1.5 to 2 centimeters below it. The tissue is actually stiffer, closer to the capsule. We got to be careful not to push too hard with the probe whenever we're doing these scans, because we can actually make the tissue stiffer just from extrinsic compression. We have image guidance for these exams. So we have a visual guide to avoid the vessels whenever we're sampling. For the liver, we use segments 5 and 8. I think it's just because these are easier segments to get to. You can go in between the ribs. You can avoid bowel gas. For the spleen, it's pretty much the same thing. We're trying to also avoid the capsule of the spleen because, again, it's stiffer towards that capsule. But to me, the spleen is a bit more challenging when doing elastography just because it's a smaller organ and it's harder to avoid that capsule. And I wanted to show the different color shades correlating with the varying degrees of stiffness. And so the color scale on the far left of the image is with the stiffness degrees. So blue being less stiff, red being more stiff. This is a major benefit of having imaging with 2D shear wave elastography is that you have a color map and it can tell you where the most consistent color is. So the image on the top left has a normal stiffness at 1 meters per second, while the image in the middle, it continues to go up. It's more green at 1.5 meters per second. And then the image on the top right shows a very stiff liver. You can appreciate some reds mixed in with yellows and greens. Their elastography value was 2.35, which is quite high. And this is a real-time cine clip showing just how quickly elastography samples can be obtained. It only takes a few seconds to acquire in a cooperative patient. Now, I know this can be really difficult in our pediatric patients, but notice that the blood vessels are being avoided for optimal imaging. Also, every frame has a consistent color. So this is our visual guide to maintain quality samples. And so if it keeps playing blues, 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 then all of a sudden you have a red sample, then you know that is probably an artifact and not a good place to take a measurement. And then at the end of an elastography exam, the machine calculates the median stiffness and the IQR median ratio percentage. And so this percentage should always be less than 15% if you are using meters per second, or 30%, less than 30% if using kilopascals. If this percentage is higher than those values, the measurements are unreliable and they need to be redone. And the same process is used for the spleen as well. So it uses the IQR median ratio, and it should also be under 15% for meters per second or 30% for kilopascals. So most vendors have a quality map with elastography. I think it's great. Ours is red and yellow. So if we are having trouble knowing where the best sample is, we can look at this map for guidance of where the more accurate measurements are located. But I do want to add, elastography does have artifacts. And so one known artifact is the blue line artifact, which you can see on this image. If this line is present, don't use the sample, as the stiffness will be unreliably low. And one important idea that I want to note is that portal hypertension is not just cirrhosis. It's often assumed that a patient has portal hypertension, they must have a cirrhotic liver. Well, this just isn't true. There's many other reasons to have portal hypertension. So now we've probably all heard of portal hypertension at some point, but did you know that there are 3 different types of portal hypertension? Today, we're going to cover them all. So the 3 types are prehepatic, intrahepatic, and posthepatic portal hypertension. So prehepatic portal hypertension is increased portal pressures before or just outside of the liver. And this may be from either a portal vein or splenic vein problem. So some of the findings that we may see on ultrasound to explain the cause of prehepatic portal hypertension may be portal vein thrombosis, either in the acute or the chronic setting. Portal vein stenosis can also be another cause. Splenic vein thrombosis can also be a reason to have prehepatic portal hypertension. This is also called sinestral or left-sided portal hypertension. A patient can have a mass that's compressing the portal system, or even a vascular anomaly like an arteriovenous malformation can cause prehepatic portal hypertension. So as we go through each type of portal hypertension, we're going to discuss what findings to expect in the liver itself, the hepatic vasculature, and any other sonographic findings to be on the lookout for. So with prehepatic portal hypertension, liver elastography should be completely normal. The problem's happening before it ever reaches the liver. So unless there's confounding factors, like we have already discussed, this number should be within normal limits. The liver contour should also be smooth. But as far as the vasculature on ultrasound, you may find portal vein stenosis, acute portal vein thrombosis, or chronic portal vein thrombosis with cavernous transformation, or maybe splenic vein thrombosis. Additionally, secondary signs of portal hypertension can be seen on ultrasound, like gallbladder wall varices and portal biliopathy. And this is a patient that had prehepatic portal hypertension with a stenotic main portal vein. You can appreciate the stenosis on the grayscale image on the left, and then the image on the right shows aliasing of color flow at the stenosis, which indicates the velocities are much higher in that specific location, as well as there's chaotic flow just distal to that stenosis. Now, to prove that there is a gradient in flow and to see how significant it is, it's important to document the velocities with spectral waveforms before, at, and after the stenosis. So in this patient, the pre-velocities were 28 centimeters per second. Then it jumped up to 265 centimeters per second. And then just distal to that stenosis, it was 243 with post-stenotic turbulence. Sorry, I was having trouble with my arrows. So that's a 9 times velocity gradient between the pre-stenosis and the site of stenosis, indicating that a hemodynamically significant stenosis is at the main portal vein. So in this patient, portal blood flow will have trouble going into the liver because of this tight stenosis, and portal pressures will increase. This is a patient that had prehepatic portal hypertension and was found to have acute main portal vein thrombosis. Notice that in the acute setting, the clot distends the vessel lumen. And the image on the left shows the main portal vein at the hilum of the liver with an echogenic area of clot visualized and being measured. And then this is all the way to the head of the pancreas, which is labeled. Just to prove this is a real finding, always use color Doppler just to show the lack of flow. In the acute setting, this thrombus can be tricky. It's isoechoic to the liver, and it's really difficult to see sometimes. And now this is a patient with prehepatic portal hypertension with an interesting tangle of vessels at the hilum of the liver. Instead of finding a main portal vein, there are multiple tortuous portal vein collaterals that are feeding into the liver. And those tangle of vessels are called cavernous transformation or a cavernoma. And this is seen with chronic portal vein thrombosis, as it does take time for collateral vessels to form. Always use spectral Doppler to prove that those are actually portal veins and not hepatic arteries, because you can actually get collaterals that mimic a cavernous transformation in the setting of hepatic artery thrombosis. And this is an MRI of a patient with chronic main portal vein thrombosis and cavernous transformation. I think it's impressive how tortuous these collaterals become over time, as well as how large they can get. And this is an axial view at the liver hilum, showing tortuous collaterals extending from the head of the pancreas and going into the liver in a patient with known chronic portal vein thrombosis. The bright vessels at the liver hilum represent the cavernous transformation on this MRI. And as a caution, Portal vein collaterals can be numerous, tortuous vessels like what's typically seen, like what I've already shown, or they can sometimes be just one or two larger collaterals that can mimic a main portal vein, a native main portal vein. It's a really good fake out. A clue that's probably not the main portal vein is that it will still be just a little bit tortuous and not completely straight like an actual native main portal vein. This is a patient who did have just one nice collateral, but you can see how it kind of turns a little bit towards the hilum of the liver. Now, splenic vein thrombosis can also be a reason to have prehepatic portal hypertension. And this is a patient that had pancreatitis and ended up with splenic vein thrombosis. Now, keep in mind that splenic vein thrombosis can be a complication of pancreatitis, and it's always important to assess in these patients. And this is a sagittal view of the splenic vein at the hilum of the spleen. On grayscale, you can see the splenic vein, but on B-flow imaging, there's no flow closer to the pancreas. And this is where the thrombosis is. So when the splenic vein cannot flow back into the portal system via its normal pathway, it then becomes congested and flows the wrong direction back into the spleen, causing splenomegaly and portal hypertension. So if you suspect that you have found a patient with prehepatic portal hypertension, also look for some secondary signs. One place to look is the gallbladder. So the gallbladder wall develops varices in the setting of portal hypertension. And these are often seen in the setting of chronic portal vein thrombosis patients. So on this transverse image, the gallbladder wall is thickened from varices, which you can already appreciate on the grayscale image on the left, and it's confirmed with color Doppler in the image on the right. In the setting of chronic portal vein thrombosis, you can also get portal biliopathy. And this is just a fancy term for the bile ducts being squished and becoming dilated. In patients with chronic portal vein thrombosis, they develop cavernous transformation, which we've already discussed. With so many abnormal vessels sitting at that hilum, they end up causing extrinsic compression of the bile ducts. So this is a patient with a cavernoma, as seen on the left, and the enlarged CBD being measured on the right. This compression, it can cause issues with bile drainage for patients with chronic portal vein thrombosis. Moving on. Now we are going to discuss intrahepatic portal hypertension, which is the most common form of portal hypertension in pediatrics. The majority of intrahepatic portal hypertension patients have some form of chronic liver disease, either with fibrosis or very advanced cirrhosis. Another intrahepatic cause is seen in patients undergoing chemotherapy or bone marrow transplant, which is called SOS, or hepatic sinusoidal obstructive syndrome. It's formerly known as VOD, or veno-occlusive disease. This is a toxic injury to the liver, causing thrombosis of the hepatic venules. So these are tiny veins that are thrombosed, but they're ones that we can't see on ultrasound, but the liver becomes swollen and big in response to it. And this causes increased portal pressures and significant portal hypertension. As far as the liver elastography, with intrahepatic portal hypertension, their numbers will be elevated. Depending on how bad their fibrosis has progressed, this number could be quite high. So with SOS, liver elastography is high before treatment, but should progress downward after treatment if it begins working well. And then looking at the liver capsule, if a patient does have cirrhosis, you would expect to see irregularity of the capsule. This is why it's so important to look with a linear probe on every single patient being worked up for portal hypertension. So as far as the vasculature, the hepatic veins will become dampened and they'll lose their phasicity because the liver is becoming stiff and non-compliant. The main portal vein slows down or reverses. Flow velocities less than 15 to 20 centimeters per second is a sign of increased portal pressures, and then along with increased pulsatility. And then with stiffening of the liver, the hepatic resistive indices will also be elevated at over 0.8. So checking the liver surface may be the most important evaluation technique for intrahepatic portal hypertension. The most accurate single sign of liver cirrhosis is a nodular surface. And this is an example of a patient with severe liver disease that has led to cirrhosis with an irregular liver surface. It's pretty straightforward. Liver cirrhosis is also characterized by changes in the liver volume distribution. So typically the right lobe and medial left lobe become small, the lateral left lobe and the caudate lobe become enlarged. So on the left is a transverse view of the left lobe of the liver with an enlarged caudate lobe labeled. It's so large, it could definitely be mistaken for a mass. The image on the right shows the caudate and the sagittal view. You can also appreciate how much smaller the left lobe is compared to the caudate in this patient with cirrhosis. So what's important to note about intrahepatic portal hypertension is that you're not typically going to find a vascular reason to have portal hypertension. The problem is with the liver itself, but there will be waveform changes seen as a result of the sick liver. So the main portal vein is going to be slow, be to and fro, or be completely reversed because of the increased portal pressures. The hepatic arteries will have high resistive indices because of the increased hepatic resistance, like in this patient that had a RI of 0.87. The hepatic vein waveforms will not be multiphasic and will be dampened, like on this waveform, which is mostly monophasic with decreased phasicity. And then the hepatic veins can also become stenotic as a result of a stiff liver parenchyma. An important secondary sign to look for with this type of portal hypertension is recanalization of the paraumbilical veins. So this happens when the portal hypertension forces the blood flow backwards from the left portal vein. These eventually drain into the anterior abdominal wall veins as a portosystemic shunt. And you can find this pathway if you look at the left portal vein, as these veins are connected and they will travel outside the liver towards your transducer. Again, this is where we get the caput medusa sign because this opens up in the setting of severe portal hypertension. Now, the third and last form of portal hypertension is post-hepatic portal hypertension. This type of portal hypertension happens when the liver has difficulty with outflow and becomes congested and it can't drain well. Some findings that we can see with ultrasound are hepatic vein stenosis or even thrombosis, which is called Budd-Chiari syndrome. The IVC can become stenosed or thrombosed, not allowing the hepatic veins to drain well and making the liver become congested. And another cause of post-hepatic portal hypertension is increased right-sided heart pressures, like patients in heart failure. As far as the liver elastography, these liver numbers will be high. The liver becomes stiff because of outflow issues and congestion. And so the liver contour should still be smooth in these patients, as the stiff liver is not from cirrhosis. As far as vasculature, if the IVC or hepatic veins are stenotic, they'll lose their phasicity, especially more peripherally in the liver. If they are completely thrombosed, well, obviously you won't find any flow, or you may see an obvious clot sitting in them. With increased right-sided heart pressures, the hepatic veins and IVC will become enlarged and have increased pulsatility. In any of these cases, when the hepatic veins have trouble draining and they find collateral pathways back to the heart, they end up collateralizing between themselves. You can see these hepatic vein to hepatic vein collaterals on ultrasound. With the liver being congested, the portal vein also meets resistance and has trouble flowing into the liver. So the flow may be to and fro, slow, or reversed. And it can also be pulsatile. And the hepatic artery resistive indices are also elevated as well. Normal hepatic vein waveforms with spectral Dopplers should always be reflective of the cardiac cycle. So the way to describe this waveform is multiphasic. It goes above and below the baseline multiple times throughout the cardiac cycle, like on this image. Seeing phasicity is reassuring that blood flow is draining adequately back to the heart without obstruction. So when you lose this phasicity is when you should become concerned that there may be some flow obstruction happening. Here's an example of a patient with post-hepatic portal hypertension. So notice the hepatic veins are stenotic at their confluence with the IVC. Let me get the arrow for you. You can appreciate the stenosis on the grayscale image on the left. And on the color Doppler, you can also appreciate an area of aliasing, which indicates there's a focal area of increased velocities in this patient. So this area was sampled with spectral Doppler to prove that there was a hemodynamically significant stenosis. Now, it seems weird, but it's super important to angle correct when sampling the hepatic veins if you think that there is a stenosis. The only way to get an accurate velocity measurement is by angle correcting and making sure the angle is 60 degrees or less and parallel with the vessel wall. So in this patient, the area of stenosis measured very high at 219 centimeters per second. Sampling just peripheral to that stenosis, the velocities go down to only 36. So that's a 6-time flow gradient between the two, which is significant. But also notice how flat and dampened that waveform looks. Definitely not multiphasic, and shows that there is a significant outflow problem in this patient. And so with the outflow issues, like I said, the hepatic veins try to find alternative pathways back to the heart. Oftentimes, if the obstruction is severe enough, they will end up collateralizing between themselves. And this is something we can see on ultrasound. So in this patient with Budd-Chiari, the right hepatic vein was obstructed and going the wrong direction. It's red instead of blue. But notice that there is a direct communication between the right and the middle hepatic veins. And this is its way of just finding an alternative pathway back to the heart. So this was a liver transplant patient with concerns for portal hypertension. On grayscale imaging, you can see that there may be a stenosis at the upper IVC at the area of anastomosis. When sampling that area, the velocities were high. They were at 251 centimeters per second. And just inferior to that suspected stenosis, the velocities go down to 34. And it also loses its phasicity if you look at that waveform. The flow gradient is 7 times. Now, with the IVC, if you ever suspect that there are any flow obstructions closer to the heart, always check the lowermost part of it. So when the flow is obstructing going back to the heart, the lower IVC, it has to find a different pathway back. And so in these patients with significant stenosis closer to the heart, the lower IVC will either become to and fro or completely backwards because it's finding an alternative pathway back. And so this patient, they had a significant stenosis up high, and their lower IVC was completely reversed down low, which proved it was a hemodynamically significant stenosis. Now, patients with right-sided heart failure, their IVCs and hepatic veins will be ginormous. As soon as you put the probe down, you'll notice that there is something abnormal going on here. The image on the left is a sagittal view of a dilated IVC, and the image on the right shows significantly dilated hepatic veins in a patient with increased right-sided heart pressures. The waveforms in these patients will be pulsatile, as you can see in these images. And again, because of the increased right-sided heart pressures, the liver has trouble draining and becomes congested. The portal pressures are increased and the portal flow has trouble coming into the liver, causing post-hepatic portal hypertension. Now to go over some of the secondary findings that can be seen with any type of portal hypertension. These can be seen with prehepatic, intrahepatic, or post-hepatic portal hypertension. Assessing for these findings can help us understand if their portal hypertension is clinically significant, or if following these patients over time, these can be used as signs if it's becoming worse. If any of these patients can end up getting ascites, bowel wall thickening, they can get GE varices, their portal vein size may increase. You may be able to find subcapsular flow, and their spleens will become enlarged, as well as their elastography will become elevated. So ascites or free fluid is something to always assess in patients with liver problems. Just quickly glance at the area, in the area of the bladder, the right and left lower quadrants. With portal hypertension, the increased pressures can cause fluid to leak out of the vessels and into the abdomen. And you can also get bowel wall thickening with portal hypertension. The reason being the SMV and IMV are directly connected to the portal system that I showed earlier. So when the portal system has trouble flowing into the liver, the SMV and IMV have trouble draining as well. So all of this flow backs up into the bowel wall becomes edematous, and you can also get intermittent small bowel intussusceptions from this level of edema, which is what this yellow arrow is showing on the right. In portal hypertension patients, it's important to assess the GE junction to look for GE varices. To assess for GE varices, you'll need to get a longitudinal view of the left flow of the liver and the aorta. And the lesser omentum is the echogenicity between these two structures with the esophagus in view. And in this image, the arrow is pointing at the GE varices. So these are important to assess for, as this is a potential source for a significant GI bleed in a patient with portal hypertension. And I thought it would be cool to share a more invasive way to look for GE varices is an endoscopy, which is what our GI colleagues will perform as a sedated procedure. The image on the left shows an endoscopic view of significant GE varices, while the white arrows are pointing to those abnormal dilated vessels running along the esophagus. I think it's just cool that we can monitor for these varices non-invasively with ultrasound. And so like the image on the right is showing the GE varices in a patient with known portal hypertension. Whenever you scan the GE junction, also pay attention to how much thickness there is between the left lobe of the liver and the aorta. This area of echogenicity, it's the lesser omentum. And it was found in this article that if this area of thickness measures more than 1.7 times the thickness of the aorta at the same level, then portal hypertension should be considered. The lesser omentum becomes thickened because it's edematous from dilated varices and lymphatics in the setting of portal hypertension. So this patient, their lesser omentum measured 18.5 millimeters, while their aorta measured 10.5. And so this was over 1.7 times and met criteria for portal hypertension. And with portal hypertension, if the main portal vein meets resistance to the liver, then the splenic vein also will start to back up. This can be seen on ultrasound. So this is a transverse view of the pancreas with the splenic vein at the tail, and you can see it is flowing in the wrong direction. It's blue instead of red. Also pay attention to the splenic vein at the hilum of the spleen. The splenic vein should be blue and the artery should be red, unless you flip your color. But either way, they should never be going the same direction. So in this patient with a huge spleen measuring 21 centimeters, their splenic vein was flowing towards the splenic hilum in the same direction of the splenic artery. So they're both red on color Doppler, indicating the splenic vein is reversed. With splenic flow backing up into the spleen, the splenic vein, it has to find other pathways back to drain, including forming spontaneous splenorenal shunts. So these can often be found on ultrasound if they're large enough, like this ultrasound image. And this is a transverse view of the spleen and the left kidney, showing an abnormal connection between the two. And this is a diagram on the right showing the same thing. Besides splenorenal shunts, the spleen may find other pathways to drain. So sometimes you may see large collaterals close to the splenic hilum, not draining into the left renal vein. But this is an image of a patient with clinically significant portal hypertension who had very large splenic vein collaterals that can be seen on both grayscale and on color. They can be seen at the inferior pole in this patient as well. And some of these collaterals ended up finding portosystemic pathways via the iliac vessels. So these can be quite extensive in these patients. Splenolastography. We talked about this earlier in the literature that if the spleen stiffness increases over time, then those patients are at risk for a significant variceal bleed. And as more pressure builds up in the spleen, more pressure is on the varices. So these are images of splenolastography done on the same patient over the course of 9 months. This patient did have portal hypertension that we were monitoring. The first measurement was around 2.4. A few months later, it shot up to 2.7. And then a few more months, it went up to 3.2 meters per second. And guess what? This patient ended up having a significant GI bleed. So splenolastography is super helpful to monitor patients with portal hypertension. And with significant portal hypertension, the portal veins become enlarged. Criteria for an enlarged portal vein in adults is between 13 and 15 millimeters in the literature. Now, I do want to caution you a bit. There are some instances where the portal flow is so poor that the portal vein is no longer enlarged, but it becomes really small. So this is a case, it was actually a biliary atresia patient that had significant portal hypertension, but notice how tiny this portal vein ended up getting. It's blue, it's reversed, and it's also pulsatile because the adjacent artery was reflective in the waveform. And then the last finding you can see as a secondary sign of portal hypertension is hepatic subcapsular flow. This you'll need a linear probe for. The image on the left shows hepatic flow not touching the liver capsule in a patient without portal hypertension. The image on the right shows flow touching the capsule, which can be seen in patients with portal hypertension. The thought is that the portal flow slows down, the hepatic arterial flow increases. And so this increase of arterial flow can be seen extending and touching the liver capsule. In the setting of severe portal hypertension, not only can you find hepatic arterial flow touching the capsule, but you may also see it traversing the capsule, which is seen on this image of a patient with severe portal hypertension. And this is a cine clip showing subcapsular flow, again, not only touching, but also traversing the liver capsule in a patient with clinically significant portal hypertension. And this is one more secondary finding that we can assess for in these patients. So to make it a bit easier on sonographers and radiologists at our institution, we do have a liver Doppler worksheet with dedicated portions to include these extra images for patients with portal hypertension. And this is just a checklist for us whenever we're scanning these patients, just to make sure we're getting all these extra images that are super important. And it also, I think it makes it easier for dictation for the radiologist as they go through these exams. We also have a blank liver, so we can draw any abnormal vasculature that we may come across, because, man, sometimes these exams get really hard. Patient on the top left, they have chronic portal vein thrombosis with cavernous transformation. This patient ended up having a mesorex shunt because they had portal vein thrombosis. And then this bottom patient had Budd-Chiari, and you can see all the hepatic vein to hepatic vein collateral pathways. It's just easier to draw sometimes than to actually discuss it. And so treatment options for these patients, it really depends on the underlying source of the portal hypertension and the severity of disease. For medical management, beta blockers can help slow down blood flow and reduce portal pressures. Depending on where the problem is, our interventional radiology colleagues can help open up vessels where they're narrowed or they are thrombosed. They can also do TIPS procedures in patients. This is transjugular intrahepatic portosystemic shunt. It's not done as often in pediatrics. It's done often in adults. And I think mainly just the vessels are a lot smaller in kids, and it makes it a little more difficult technically. For endoscopic interventions, our GI colleagues can band or use sclerotherapy for those varices that I showed you earlier. And this can be done either when a patient's having an acute bleed, or it can be done prophylactically. Surgical interventions for patients with portal hypertension, they can do distal splenorenal shunts, because the spontaneous splenorenal shunts may not be enough to decompress. They can do a mesorex shunt bypass if they have portal vein thrombosis, or a mesocaval shunt. And then in the cases of severe liver disease and portal hypertension, ultimately a liver transplant would be the definitive treatment. So some final thoughts of mine. Remember that portal hypertension is not always from cirrhosis. There's 3 different types of portal hypertension. There's pre-hepatic, intrahepatic, and post-hepatic portal hypertension. Ultrasound is an important tool to look not only at the different types, but to also assess for secondary signs, as this can help clinicians to know if it's clinically significant. And we can also follow these patients with known portal hypertension and help identify those that may be at higher risk for variceal bleeds. And hopefully using ultrasound as a monitoring tool helps these patients avoid more invasive testing. And these are my references. And just a quick shout out to these 2 physicians. They've taught me what I know about portal hypertension and livers. This is Dr. Alberto Hernandez and Henry Justino. So thank you guys.
Sorry, I accidentally muted you. Thank you so much. That was really awesome talk. I really appreciate your time and expertise and sharing all that with us. If anybody has any questions, feel free to submit those in the chat. I know I certainly have a lot of questions. I'd love to hear from Judy and Haitwi as well. I'd love to hear a little bit about kind of just from a practical approach, kind of how you're approaching these patients. Like if you get a request for evaluating for portal hypertension, are you routinely doing a very, comprehensive assessment with, full red upper quadrant exam with Doppler and elastography? What's your kind of general just approach to those kinds of patients?
Can you hear me now? Sorry.
Yeah, sorry, I accidentally.
I'm making sure I'm unmuted. Great question. So for any patient that there is a concern about portal hypertension, we will always do at least a liver Doppler, a full liver Doppler. So we'll do hepatic veins, portal vein, hepatic artery, aorta, IVC, all the things. Elastography, we're kind of leaving up to the clinicians, how they want to use it. So if they want it, that's great, but they don't we're not like forcing that as part of the portal hypertension workup. I personally think it adds a lot of value, but we are leaving it up to the clinicians for that part.
And then one of the questions already submitted, which I knew was going to be a popular topic, was the elastography kind of cutoffs for both liver and spleen. I know you had mentioned a couple of papers about spleen elastography and kind of what the suggested cutoff value was. I know there's been a lot of work on, liver elastography and kind of defining what our cutoffs are. And there's relatively, like you mentioned, there's, gender or vendor specificity with those kind of values. And then kind of what our abnormal value cutoff should be. So if you have that normal value, kind of what do you use? So just as a kind of using patients as their individual controls and kind of just tracking it over time, or are you kind of using that in reference to those cutoff values in the literature to actually say this is abnormal, or what's your kind of how are you using those numbers?
That's a great question. I think it's a hard question to also answer because it is really vendor specific. So at our institution, we have GE machines. So any literature that we pull, we make sure that they use GEs to do their studies on. We were able to find some literature with GE vendors, and they did liver biopsy proven like numbers. And so we have values for like little babies on our machines should be closer to 1 meter per second. And then it trends up. I think it's like age 6, it's like 1.1 would be normal. So we know we have some thought or some idea of what these numbers should be on our machines, at least at our institution. And that's also been my experience doing a lot of elastography. It goes well with what a few of these articles have shown. Now, as far as spleen elastography, it is very, very new. At least in the world of pediatrics, there's not as much literature out there. And so we are using every patient becomes their own control. And so we can get a good baseline and then we will follow them over time. So if there's concern for worsening portal hypertension, then we do use elastography in that way to see if it's trending up along with maybe decreasing platelets or spleen size. Yeah.
Yeah, I know at least for us locally, like we're mainly using liver elastography for following our cardiac patients, our content patients, really not using it much for these more specific portal hypertension patients. Yeah, but Judy and Hedry, I'd love to hear how are you guys currently using this?
Yeah, I feel like we do not do a lot of liver elastographies here. I'm not sure why. Maybe it's just like a different culture, but I remember doing a lot more at Texas Children's than at CHLA. So I think it's kind of left up to our referral clinicians, but they typically will look for more or less Fontans or Fontan related liver diseases.
We seem to do a lot, but it's mostly left up to the clinician. We do have a few protocol automatic elastography add-ons. For example, the post-transplant patients who are getting biopsied, also, we kind of combine those two tests for like trending purposes over time. We don't do any spleen elastography yet, mostly because I don't know what to do with those values. Um, I think trending over time could be helpful, but our clinicians also look at like platelet count, et cetera, and like spleen size. So I don't know. I'm gonna wait until I have some more data, I think, for before we start to do that one.
Yeah, I think it's definitely interesting. I mean, I'm not sure what you guys are using for your normal values for even for your Fontan patients, but what we use is there's that SRU white paper that was published a couple years ago, and we basically we give the KPA just as a straight number, and then we kind of include a disclaimer with some of the verbiage from that paper. There's so many variables like if you have cholestasis or inflammation or obstruction within the liver that can kind of confound those values. So we almost do kind of use it as even in those patients, kind of using it as an internal control. I forget the exact numbers. I think it's less than 4.7. We say it's the KPA. We say that's probably normal, and if it's more than I think either 14 or 15, we say that's probably fibrotic, but we kind of just give that caveat and kind of, like you said in your talk, interpreting in the clinical context of the patient rather than, strict values of this means this patient has whatever abnormality. And then another question from our chat is, you had mentioned the IQR median to make sure that those numbers are representative of, quality for the examination. So it says, does the sonographer keep trying until they get that number within the range, or do you just report the values as is and give the disclaimer that it may not be a quality study?
So at the end of our exams, we are responsible for checking our IQR numbers. And if it's too high, then we will just redo the exam. And I mean, if we can't get it, we can't get it because some patients are really difficult and
Right.
you might not be able to get it. But we do our best to pay attention to that number and just redo the samples and just to do our best to get it under that 15% for us for meters per second, or in kilopascals less than 30%. Yeah.
Okay. One other question I had was about color versus spectral Doppler. And I know doing a full Doppler study with spectral is a significant time add-on and also a significant cost as well. So I'm curious what your thoughts are on when we get an order for the indication just as portal vein thrombus or something. Our sonographers are always asking, could we just do color just to prove it's patent? The spectral I think definitely adds nuance to some of those things. But I'm curious what your thoughts are on when it's okay to just do color versus when you should do that full spectral study.
That is a great question because these are such time-consuming exams, trying to get specific locations and getting all these velocities and angle correction and all the things. I think if there's like a straightforward question, is there a portal vein thrombosis? I just feel like we could probably get away with not doing a complete spectral Doppler. I think grayscale and color is good. I think when we get in there, maybe we start seeing some funny business going on. That's probably warranted to do a full Doppler at that point. But if it's like straightforward, I mean, are the hepatic veins patent? I mean, you can see patency on color and grayscale. So we're actually trying to maybe also do that as well, get away from this full spectral Doppler, right upper quadrant with Doppler on every single one of these patients, just because it's extensive and it's time consuming. And so I think that's a great question.
Then one other question, Judy and Hydrate, I'd actually texted you about this not long ago. Are you guys using that Medivir score, the F0, F1 for stages of fibrosis, or how are you guys actually like in your report? Are you just giving the KPA or the meters per second, or how do you guys actually report out your elastography findings?
So we just report out each measurement per segment. So we do like 3 values on segment 5. We do 2 values on segment 8 in the liver. So we do a total of 5 in the liver. And so each of those numbers are reported, and then we give the median IQR. And then we let the clinicians decide what to do with that information. We do include some of like the literature, like these are what is reported, like these are the values that are reported that could go along with it being too high, but we give them the numbers and they can do with it what they would like and how they manage their patients.
Yeah, we had a case not too long ago where a clinician was very insistent that we give him the fibrosis stage with the the F0, F1, and we declined to do that.
I would agree with that. That's very interesting though.
Yeah.
Yeah, I think that might be an adult thing because the only times that I have had somebody be like, oh, I'll add this to your report was when they were an adult gastroenterologist. They also we still have we report our values in velocity, so meters per second rather than KPA because of the OG SRU paper. And they were very confused by that also. So I don't know. I think there's too much overlap between the fibrosis stages to put that in a report to have like the parents freak out, the patient freak out, depending on the age of the patient, and then the clinicians. Maybe one day we will be there.
And one of the questions was about that. What are you reporting, either meters per second or KPA? We actually report the KPA, but it sounds like maybe you guys are different. But
yeah, we do meters per second.
We do both.
Yeah.
I mean, I was thinking we should probably do both because that would be helpful. People wanted to
a little extra here.
Yeah.
That was all the questions I had. I don't see anything else on my chat. I know we're getting to the end of time. Judy and Hetwi, did you have anything else?
I guess just a quick question on billing. If you do end up doing both the liver and the spleen elastographies, do you bill for like 2 organs, or are we not at the stage where we bill for spleen yet, just because it's not really like used clinically?
Yeah, I think we're at the stage we're not billing for the spleen just yet. I think Number one, we're trying to figure out if it can be done consistently and reliably. So we're still trying to figure that part out. I mean, I think we can, but it's just going to take a little bit more time to get it figured out. So no, I think it's just one charge for the elastography, and we're including the spleen with the liver.
Okay. Thanks. And I don't know if you already mentioned it, but like, is the technique similar to the liver where you kind of like measure, below within like a centimeter of the liver capsule or
Yeah, the
avoid
spleen is so
flow?
much harder than the liver to me anyways for elastography because it's just a smaller organ to try to get that box into. And so it's hard to avoid the liver capsule. So yes, you're supposed to still avoid the splenic capsule when doing the spleen, but I find it to be way more difficult because it's just a hard one little area to try to get to avoid it. It's difficult. But yes, the same rules apply to the spleen.
I actually did have one more question. I know we talked a little bit about this yesterday, Ashley, but as far as your number of samples that you're doing for elastography, and I know you had mentioned you guys do 5. We're still doing 10. I know you had mentioned there's some literature that says probably 5 is as good as 10. Judy and Hatchby, are you guys doing 10 samples for a liver elastography, for example?
Yes, we are, but at least here. But I've done both. And yeah, I'm not sure if 10 is all that necessary, so I agree.
Yeah, we still have 10, even though the SRU like updated guidelines have fewer. Um, Probably we will reduce it at some point, just like we're reducing lots. We're trying to shorten protocols for like almost everything. So probably one day we will.
And then question from the chat was, how many samples do you get from the spleen for spleen elastography?
I believe it's supposed to be 5 as well, if I recall correctly from what I've read. We're still trying it out. So right now, I think we're just doing 2 just to make sure that we can just even be done. And little kids is extremely hard. For some reason, it's just harder to pick up. And so getting 2 seems like a task just to try to get those 2 samples. Getting 5 would be extremely difficult in some of our patients. So, but I think that is 5. I think when we start billing for it, we'll have to do 5 samples.
Questions keep coming. So if you have one measurement that's really far off from the remainder of the samples, do you count that one or do you just repeat it so that they're all kind of in a similar range?
We have the capabilities of just deleting one at a time. So I would probably take that one sample out and just redo it because it's probably more than likely it's an outlier.
Okay, so you go through and you try to get all 5 samples to be relatively representative of each other.
I want to get the most consistent and the most reliable samples. So I'm looking at the color to make sure I'm sampling where it's most appropriate. I do know that liver disease is not always homogeneous. And so I think that's also a struggle with some of these patients, especially with like cirrhosis and fibrosis. It's hard, but I'll get the most consistent color. And so hopefully those numbers will be somewhat close together and less than that 15% or 30%.